Good afternoon, everyone. So thanks for the warm welcome. So I will be presenting myself with the topic of binocular approach to patients who are having strabismus. Yeah, my screens are visible, right?
Right, go ahead.
Yeah. So my topic for presentation will be approach to binocular cases and how we can manage this patients with BYNOCS. And it is more an evidence-based practice. So as we know that we human beings are binocular creatures. So we have both the eyes. We are not monocular or multiocular creatures. So we have two eyes with each eye perceiving slightly different view. And our brain combines these images, which gives us clear and single vision. So the advantages of having a binocular vision can be stereopsis, which is more depth perception, larger field of view, better contrast, and better resolution activity, etc. Now, to have binocular vision, it is very important to use both the eyes together. So having coordinating the use of two eyes as a team can also lead to visual disorders. Not in other way, not being able to aim these two eyes correctly can produce varieties of motor or sensory eye problems, which an example are amblyopia, strabismus, as I and Sandra ma'am has mentioned about non-strabismic binocular vision anomalies. So my talk will be only focusing about strabismus. So as we know that strabismus are divided into large group, which is intermittent ones, as an example, exotropia or esotropia, intermittent, constant exotropia, constant esotropia, and either left hypertropia or right hypertropia. Now, the difficulties by which the patient will be going through can be complaining about diminish of vision, which is blurring of vision. So either child or guardian, any one of them can complain about diminution of vision, squinting of eyes, as you always go through that the patient will have exotropia or esotropia. So it will be manifest deviation, which will be seen by the parents. Poor academic performance, as Sandra ma'am has mentioned, because of not able to read correctly, not able to focus correctly. Abnormal head posture as a compensation of squint. And also some guardians will complain that they have underwent already a procedures or they have taken treatment for that, but they are not happy. Now, the traditional method to correct this is either patient will be provided by patching occlusion or penalization, or sometimes surgical intervention for extraocular muscles. Also, very important, sometimes the patient will also be given addition lenses, either esotropia or exotropia with minus lenses to over accommodate and make the eye deviation proper. Now, what we do in active vision therapy, that the patient will be given first, any patients who are having manifest squint should be given an optimal correction. So as an example, myopia, hyperopia should be corrected adequate. And if there is a manifest deviation, so let it be exotropia, esotropia, should be corrected by prisms, either by Fresnel or Groudon prisms, by depending on the magnitude of the tropias of the patient. Then the therapies will be starting with a phase 2, which will eliminate the eye suppression. So this kind of patient, because of strabismus, constant strabismus, will have dense suppression. Let it be central scotoma, which is suppression for central or peripheral. Now, this kind of patients will start the therapy by eliminating the eye suppression on the basis of monocular fixation in binocular field. Now, how this therapy is done, I will explain you in further slides. Then we will focus on eye movements, eye abilities of the patient. So we will train their saccades and pursuits. Then the third phase of the therapy will slowly, once the elimination of the suppression is done, we will start building the stereopsis of the patient. So because of the constant strabismus, these patients will not have stereopsis, whether it will be gross or random dot stereogram. So this patient, the third phase of the therapy will be to developing the stereopsis of the patient. Then once we have developed the stereopsis, we will develop the patient's ability to converge or diverge, depending upon the eye deviation. So if the patient is having esotropia, we will try to build up the negative fusional vergence. So the ability of the eyes to diverge properly. If, as an example, if patient is having exotropia, we will more focus on PFP development, which is positive fusional vergences. So we will focus their ability of the eyes to develop good convergence so that their eyes are aligned more properly. How this is done? This is an example of the First image you can see, it is an MFBF activities, which is monocular fixation in binocular field. So patient will be presented with a two object, which is one of red or one of green, one of blue or green, and the patient will be starting the therapies, which will eliminate the patient suppression. Then the second image, which you can see, is an activity to improve their stereopsis, 3D perception. Then once this is done, we will also develop their functional vergences on the basis of random dot stereogram. I will take you to a few case studies which we have done to prove the effectiveness of this therapy. So this girl was of 9 years of age with isometropic amblyopia and intermittent exotropia. So the deviation of the exotropia was intermittent. The distance visual acuity, as you can see, was 6/12 for distance in both days and in 6 for near. Prism bar cover test for near was 30 prism diopter and 45 prism diopter for distance with poor control, which is grade 3. So whenever we are dealing with intermittent exotropia patient, we grade their control over the exotropia. So how well they are controlling their exotropia. So how well they are aligning their eyes by the help of convergence ability of the patient. So stereopsis of the patient was 120 arc second, which is poor, and for distance was absent. Patient underwent 30 sessions of an active vision therapy. Post 30 session, you can see the visual acuity also showed an improvement to 6.6. Simultaneously, as a part of therapy, we are also given therapies for management of intermittent exotropia by active vision therapy. So we developed the patient's fusional vergences, which is convergence. And post 30 sessions, you can see the visual acuity improvement and intermittent exotropia improvement. So from 30 prism diopter, it showed an improvement to 10 prism diopter, and from 45 prism diopter to 15 prism diopter with good control, which is grade 1. So now the patient was able to align their eyes more properly. Simultaneously, stereopsis also showed an improvement from 120 to 60 arc second. And now the patient develops stereopsis for distance of 120 arc second. I will take you to the second case, which is of full refractive accommodation esotropia with amblyopia. So this boy was of 7 years of age with both the eyes distance visual acuity of 6/12 and near visual acuity of N6. As I mentioned, patient was having full refractive accommodative esotropia. So the prescription was plus 4.5 in both the eyes. Prism bar cover test without the correction was of 20 prism diopter for near and 10 prism diopter for distance. But with proper correction, educate correction, patient was having orthophoria. So patient was not having any manifest deviation. Because of the refractive esotropia, the suppression for distance as well as near was present. So for this patient, we have undergone 30 sessions of active vision therapy. So the therapies consisted of eliminating the eye suppression as well as building up the stereopsis of the patient. Post 30 sessions, you can see the visual acuity outcomes from 6/12 to 6.6 patient got. Also, because of refractive accommodative esotropia, with stereopsis was absent, now the patient was able to perceive stereopsis of 20 arc second for near and 75 arc second for distance. Last case, I will present you about manifest deviation. So this girl was of 9 years of age with strabismic amblyopia, which is of exotropia in the left eye, which was constant. Now, the distance visual acuity of the patient was 6.6 in both the eyes. Prism bar cover test, as I mentioned, was having 25 prism diopter for near and 20 prism diopter for distance. Stereopsis for distance as well as near was absent because of constant strabismus. In this case, the primary step of the management should be or would be a surgical intervention for the exotropia. But since the patient was not ready to try the surgery, we tried our active vision therapy program for the patient. So we gave a Fresnel prisms of 20 prism diopter for the correction of the squint. And we started the therapy, which is active vision therapy with prismotherapy. So over the prism, the patient did a therapy for building up their stereopsis and eliminating eye suppression. Post 30 sessions, you can see the visual acuity outcome. Patient achieved good vision, which is, So patient was having a good vision, 6.6. Prism bar cover test was same as before because the patient was given a substitution of Fresnel prisms. But now patient was able to perceive 3D vision, which is stereopsis, very important part of our day-to-day life. So patient got a 10 arc second for near stereopsis and 120 arc second for distance. on random.stereograph. Now, the take-home message or the summary of my talk will be the importance of binocular vision, why binocular vision, having a good binocular vision is important in our day-to-day life. Also, that the role of active vision therapy in patient having strabismus is very important. So we can develop stereopsis in patients who are having constant exotropia or constant esotropia or any manifest deviation. Also, very important is how you use the tool of active vision therapy and which tool you use as in for the therapy of the patient. And successful treatment with the support of prisms and active vision therapy can always be obtained in patients who are having manifest strabismus or intermittent strabismus. With proper guidance, you can treat your patients even on virtual reality or virtual platform. So as an example, if patient cannot come for the therapies to your clinic or to your place physically, you can always have a tool which can be a virtual platform by which you can give the therapies, as I mentioned in my slides. Also, achieving the world as a three-dimensional space from two-dimensional for any patients who are having strabismus will make an immediate and amazing difference in our patients' lives. Thank you for giving me a chance to present.